Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I am your host, Rebecca Sapp. I'm a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy and immunology. Our podcast series will use interviews with thought leaders to keep up to date on new developments and to review core topics. Today's edition of our Conversations from the World of Allergy podcast series will focus on the topic of eosinophilic esophagitis. We are pleased to welcome Dr. Evan Dellon. Dr. Dellon is a professor in the Department of Medicine and the Division of Gastroenterology at University of North Carolina and the director for the Center of Esophageal Diseases. He is an epidemiologist and a clinical and translational researcher who focuses on esophageal diseases, particularly eosinophilic esophagitis. His work focuses on optimizing the diagnosis, characterizing the epidemiology, studying the pathogenesis, and refining treatment and monitoring of EoE with the overall goal of improving patient care and outcomes in EoE. Dr. Dellon, thank you so much for taking the time to join us today.
Yeah, thanks so much. It's great to be here.
You're my first non-allergist to interview on this show, which is exciting.
Yeah, that's a great honor. I know just enough about allergy to be dangerous.
Perfect. We like to start by getting to know our guests a little bit. Can you tell us a little bit about yourself and maybe include something you like to do outside of medicine?
Yeah, sure. So I'm as you just said, I'm down in Chapel Hill, and I've been here just over 20 years. Came down here for GI training initially, and stayed on. Um, and work both clinically, and I spend about 2/3 of my time plus now on the research side of things. Outside of that, I enjoy traveling, skiing, and then of course spending time with family and the kids.
Where's your favorite place to ski?
Oh, that's a good question. I like some of the places out in Utah are great. Snowbird and Alta are favorites, but we've done some family trips more in Colorado recently, out of Breckenridge, which has been pretty fun and very family friendly.
Yeah, all beautiful places. Hard
Yeah.
to find a place to ski in North Carolina.
Yeah, yes. There's some places out in the western part of the state and in West Virginia that are small, but I did a good amount of skiing. I was up in Boston for residency, so post call weekends driving up to New Hampshire and Vermont and all the way up to JP up there by Canada and stuff. So those were fun weekends.
Taking advantage of the golden weekend.
Yes, exactly.
Perfect. So, what made you choose to study EoE? Of all the kind of different specialties within gastroenterology, why eosinophilic esophagitis?
Yeah, it was sort of serendipitous, I would say. So I started GI fellowship, and I actually had never heard of EoE. This was in the early 2000s, and didn't know about it med school or residency. And I came to a fellowship, and I really thought I would be getting called in most nights for GI bleeding, and trying to do all kinds of maneuvers to stop bleeding. But it turns out every time I was on call, I got called in for a food impaction, and almost nobody was GI bleeding, but everybody had food impactions. And of course, I first thought moving to the South, something about the barbecue down here or something like that. But actually, it turned out to be EoE. And at that time, there really was very little known about it. There were only a few hundred papers, about half of which were reviews. And so I actually got really interested in yeah, the condition. And we had a really good and have a really good esophageal group down here, and so there was sort of the right mentoring to learn about that. Nobody was studying it, so it could be sort of the my own area where I worked. And even simple things like trying to write a research project initially, a research question, there wasn't a disease definition. And so just answering or starting to approach simple questions like that was really how I got into it. I was able to read really every paper in the field, and then sort of go from there. And that was as I got into it during my research fellowship time. That was right around the time the first guidelines came out as well, which were luckily consistent with what I put in my proposals for for research. And yeah, and from there, I think it was really lucky, a combination of sort of the right timing, a big increase in the number of cases that we were seeing, and just fantastic research mentorship in the area.
That's great. It'd be hard to read all the EoE papers if you started in EoE now, just because
Right.
there's the explosion of research, which is great.
Oh yeah. Yeah, no, it's been amazing to see the change over the years.
So, what is the definition of EoE?
Right now, we define it as a chronic allergic condition, and it's comprised of two parts. One is you do have to have clinical symptoms and a presentation consistent with it, which we sort of loop into a term esophageal dysfunction. I'm sure we'll go into detail about the symptoms. And then at the same time, you have to have elevated eosinophils in the esophagus, and that's defined now as at least 15 eos per high power field. And what that means is, during endoscopy, we're taking a biopsy. The pathologist will look on the entire biopsy and pick the area of peak inflammation and actually count the eosinophils there. And so if it's more than 15, you can strongly consider the diagnosis. But there is this third step. And historically, that third step was you had to give someone a proton pump inhibitor and have them fail it to be diagnosed with EoE. And there was sort of this initial distinction in the field that EoE and GERD could not overlap, and PPIs only treated GERD. And we know that's not the case anymore. And PPIs are now a treatment for EoE. But nevertheless, there are a bunch of things that can cause eosinophils in the esophagus besides EoE, GERD being the most common. But you can also have Crohn's of the esophagus. You can have other rheumatologic or motility conditions that do it. You can have drug reactions, infections, a number of things. And so, as the provider, you've got to go through that list and make sure you're really thinking about EoE, because obviously the treatments are pretty divergent between other conditions and what we're going to do for EoE. And so then after that, that's sort of how you can diagnose it, and that's what it is.
So, why does sometimes when you have reflux, do you get this eosinophilic inflammation and sometimes you don't? Is there something different about people who develop eosinophilia in response to this acid reflux?
Yeah, it's really interesting. In the early 80s, actually, eosinophils in the esophagus were actually the biopsy marker of GERD. And low levels seem to be a non-specific response to just acid exposure. Localized in the distal esophagus, typically relatively low numbers most of the time, 7, 8, but nobody really counted them at that time. They just saw that, and they saw other what they would call reactive changes, which is sort of the dilated intracellular spaces, which also is the refluxate causes the barrier damage and opens up, and then some proliferative changes as well. Those are long known to be reflux changes. And actually, because of that, when people started seeing eosinophils in the esophagus, they always attributed to reflux, even at high levels. And that's sort of where the PPI treatment came in, and realizing, oh, if you're not responding to PPIs, then it must be an allergy mechanism. So there is this direct effect of antacid, but the relationship between the two is actually much more complicated. So I think in some cases, GERD can actually drive actually an EoE-like picture. So you can get acid exposure, digestive juice exposure into the esophagus. It will weaken the barrier, and then you actually get antigen penetration into the esophagus from reflux, and then that starts the T2 kind of response. So I have people who it looks like at the bottom of the esophagus, terrible reflux, acid burns, erosive disease. But at the top of the esophagus, it looks like EoE. And if you can effectively treat the reflux, everything goes away. So there's that kind of relation. And then it can work the other way too. So for people with EoE primarily, if the esophagus is inflamed and less compliant, then actually you get secondary reflux. The esophagus becomes less good at clearing out physiologic reflux, and then you have secondary reflux. And then there's a group of people, reflux is so common, right? About a quarter of the people in the US, just by odds, a quarter of people with EoE might have superimposed reflux that's totally unrelated. So there's a pretty complicated interaction there that does take a little while clinically in some people to kind of separate out.
It does sound like, though, there's some degree of what we think about with atopic dermatitis, where the barrier dysfunction leads to antigen getting in and sensitization and then increased allergic disease from that. And it sounds like there is at least some play of that going on in the esophagus.
Yeah, there is. And I think it's as more and more people are investigating the pathogenesis, it does seem like the barrier is likely the primary issue. Now we know that it can be intrinsic. There are polymorphisms in certain protease inhibitors in the esophageal barrier. like Sphinx 7 or callicrin 5, that can predispose to EoE in certain people. We also know there's a very nice experimental model of EoE from Ben Wright down in Mayo, Arizona, where detergent exposure in the esophagus, which will disrupt the barrier, you know uh, uh, leads to EoE. And I think that's one of the theories of why EoE might be on the rise. And again, similar to atopic dermatitis, that if you can heal the barrier, then things may get a lot better.
And you mentioned that not only do you have to have the pathology to kind of have EoE, but also the symptoms. And I know kids and adults get EoE, but it looks a little bit different. Can you tell us a little bit about the symptoms we're looking for in kids versus adults?
Yeah, so adolescent and adults, the hallmark symptom is really trouble swallowing, dysphagia, and food impaction, right? So food gets stuck and can't get up or down. And the symptoms in kids really are very different, right? So in the youngest kids, you're going to have growth problems and failure to thrive. You might have vomiting or abdominal pain as they get to be a little bit older. And then in more like school age kids, it's going to be, again, vomiting, pain, sometimes heartburn, sometimes regurgitation. Now, what's tricky is it can be hard to separate out. I think little kids have a hard time expressing food sticking or dysphagia. And so what parents observe as vomiting might actually be food sticking in the esophagus as dysphagia and then being vomited back up. And I think it's really comes down to the provider, both on the adult and the pediatric side, to take a pretty careful history and get a sense of is it really true? Like you eat 15 minutes later, then you vomit up food that's been, partially digested, or is it like eating and then, immediate discomfort and then vomiting up food? And then the other thing in adults is that it's amazing the degree of compensation that happens with trouble swallowing. And when you talk to patients, many times, they may be in with a food impaction. They'll say, "Oh, this is the first time this has ever happened. It's never happened before." But when you really get into it, they've been having food stick intermittently for years, if not decades for some of them. And what happens is they start eating slowly or chewing their food into mush or cutting their food into tiny pieces, avoiding things that stick, drinking a lot of fluid after each bite. And that, they're fine, they can kind of cope, but if they're not careful, then they can get an impaction. And another subtle sign is pill dysphagia. And so some people, they've never learned to swallow pills or they're chewing the pills. And so you can bring out all of these elements on history. These are now called impact behaviors, which is an acronym for like imbibing fluids, modifying foods or the way you eat, um, prolonged meal times for the P, avoiding foods that have hard textures, chewing thoroughly, and then turning away pills. And so it's a way to think about it as you're doing a history.
Oh, I
And
like
then
that.
we think, the symptoms are very different, but the disease underlying is the same. And we think these symptoms may be on a continuum where little kids haven't had the disease for long enough, where it's primarily inflammatory. And then as the disease persists, you get into the more fibrotic aspect of the disease and dysphagia.
No, I've definitely had patients where when you start asking them, they're like, "Oh yeah, I've had to, chew my food longer and longer. I've had to drink more and more fluids." And it's just they've just adapted and they haven't even realized that it was anything unusual.
Yeah, yeah. The burden of the symptoms, once you really get into it, is pretty impressive. Like people will, either won't go out to eat, or when they go out to eat, they have to identify where the bathroom is in case something gets stuck. Or if they're at a business meal, they just don't eat. And for the kids, it's they may not, they also may really be having difficulty in social situations.
Now, we talked about a little bit about risk factors in terms of reflux. What other risk factors have been identified?
Yeah, so the main one really to suspect it clinically is atopic conditions. And so while it's true that 60 to 80% of EoE patients have atopic conditions, there's newer data coming out showing that the more atopic conditions you have, the more likely it is that you have EoE. And I think from the allergy perspective, that's a really important thing. So I have some patients who actually present to an allergist with what they're telling the allergist is a food allergy. And what they're describing is I take a bite, I can't breathe, my mouth froths, and I think, I need to take an EpiPen or something. But actually, there's no rash, there's no hypotension, there's no other signs of anaphylaxis, and it's a food impaction. And so that's often how I might get referred patients for endoscopy. But I think there's pretty strong data now that if you're seeing someone and they have a higher number of two, three, four atopic conditions, there's going to be like a 5 or 10% chance that they may have EoE if they have any GI symptoms at all. And so I think that's probably the strongest risk factor that we think about. And there's one study Emily McGowan did out at UVA where she actually asked her clinic patients about GI symptoms, and a very large proportion, like a third, actually will report GI symptoms that had never been evaluated before. So I think it's pretty common, and the group at CHOP showed that about 5% of all kids with IG-mediated food allergies had EoE. So it really increases the risk in those situations.
Absolutely. I think one of the really interesting things about the pathophysiology of EoE that we've learned is that even though we define it by the eosinophilia, that may not actually be what's causing the disease. And we kind of learned that partly because of these using IL-5 inhibitors. I know you were recently involved in a trial, the Messina trial looking at benralizumab. Would you mind telling us a little bit about that and kind of what was learned?
Yeah, we probably have the disease named incorrectly. It probably should be like atopic esophagitis, like atopic dermatitis. But yeah, this study was really interesting. It was of benralizumab, which is an anti-IL-5 receptor antibody, so it rapidly depletes eosinophils. And we all thought this was going to be a complete chip shot in terms of clinical efficacy. And so it was a big phase 3 randomized trial, placebo-controlled, and in fact, when you look at the eosinophil counts after the 6 months of the initial blinded phase, there were incredibly high histologic response rates. So 85% plus in the active group had biopsies that met the threshold of low eosinophil counts, and almost none in the placebo group. But when you started to look at other outcomes, the other co-primary outcome was symptoms of dysphagia, and there was no difference between placebo and the active therapy, which happens sometimes in EoE trials because of the difficulty measuring symptoms. But in this case, it was probably correct because there was also no change in the endoscopic severity. So the people who had been on benralizumab looked the same as the placebo group. They didn't have any healing of their esophagus visually. And when you looked at more histologic features, we have this thing called the EoE HSS, which is the histologic scoring system. It looks at seven other findings besides just the eosinophil count. And so basically it looked like someone erased the eosinophils from the biopsy, but you still had all the proliferative changes, all the basal zone hyperplasia, you had the lamina propria fibrosis, you had the dilated intracellular state bases, none of that stuff healed. And then when you looked at the genetic assessment, it also didn't reverse. Only the eosinophil related factors went down, and there were some factors that seemed to increase paradoxically. So it was really a surprising result, and I think it showed us, particularly in the context of a couple other trials, some with mepolizumab, some with a med called larentilumab, which is another eosinophil depleting agent that targeted Siglec-8, that the eosinophils are not the critical pathologic cell, which really kind of turned the field on its head. And it's a great diagnostic biomarker for sure, but I think the work is still ongoing as to what other things are causing the damage to the esophagus if it's not, if you get rid of the eosinophil and the damage is the same. And so I think, people are thinking about mast cells. And I think, if you think about it conceptually in the pathogenesis, the eosinophils at the end, but you haven't done anything to the T cells that are active. You haven't done anything to antigen exposure or any of the T2 cytokine cascades. So you would still have mast cells. The fibroblasts are still going to be active. All the cytokines are still going to be active. So I think that's probably what's going on, and it's too focused a therapy. And so it's really interesting learning from that trial.
So it sounds like the pathophysiology is still really evolving in terms of what we know about it.
Yeah. Yeah, I think so. And there was a small randomized trial of benralizumab for eosinophilic gastritis done out of Cincinnati. And they did a sub-analysis. There was the same findings where the histology got better, but really the patients didn't feel better. And In that study, they found that the pathogenic T cells were actually increased when you eliminated all the eosinophils. So that started to give some insight. And so we're still waiting for some of those analyses out of the Messina trial.
So knowing that maybe eosinophils aren't necessarily the cause, and there are not really any biomarkers for EoE at this point, are there any biomarkers on the horizon or things that people are looking at beyond kind of eosinophilic markers?
Yeah, so I think w- one of the markers that's actually pretty easy is actually the endoscopic appearance. And we have a validated way to measure that. It's the EoE endoscopic reference score, or EREFS.
Mhm.
And so this looks at things like edema, rings, exudates, furrows, and strictures. And I think this is pretty equivalent to atopic dermatitis, where if the skin is better, right, most of the time people are feeling better, and you're like, okay, it's working. And it's the same thing. Like when something works, we see it improve how the esophagus is looking. So I think that that's a nice marker. There are a lot of tissue biomarkers that actually seem to work pretty well. We have a genetic panel for gene expression. A number of the eosinophil granule proteins actually are good markers. People have reported out on mast cells. In the blood, there's a lot less that actually has been reported as promising. And part of that also is a lot of the blood stuff, you don't know if it's EoE or if it's asthma and atopic derm and just the general allergic predisposition. So right now, we're mostly recommending people follow obviously symptoms, but symptoms alone aren't enough, and also the histology and the endoscopic appearance. And I think actually the histologic scoring system, even though it's not used in practice that much yet, I think that's going to give a very nice sort of whole biopsy health of the esophageal epithelium as well. And then the last thing is that, for asthma, you guys will measure, you can measure peak flow, or, a number of sort of functional markers. We do have something called endoflip, which is a procedure done during an endoscopy, where we can put up a balloon catheter in the esophagus and we can measure esophageal compliance. And so that's another marker that can be followed to look at how stiff the esophagus is. Is the motility okay? There's certain physiomechanical properties that we can look at. And so that's an evolving marker that I think people will hear more about.
I've heard EndoFlip used more for the kind of the reflux group than I have for EoE. Is it just that the balloon inflates and then it measures compliance? Is that what it's measuring?
Yeah, it's doing a couple things. So the catheter has a very floppy balloon on it, so it doesn't dilate. And then an electrolyte fluid solution is instilled into the balloon in increments. And the catheter is covered with pressure sensors and impedance. So you know the volume that goes in the balloon, you know the pressure, and you know the conductance. And so you can get compliance curves, cross-sectional area of the esophagus. And then you also measure motility, because from the esophagus standpoint is someone suddenly put a hot dog in the esophagus. And so normally it will try to squeeze that out. And so even when people are asleep, we can measure secondary peristalsis. And so this is used, I would say, mostly clinically for motility disorders like achalasia, where they're looking at the function of the lower esophageal sphincter. They're doing an intervention on it and making sure they disrupt it. And I think for less so for GERD and for EoE, it's mostly still a research tool as we're learning the best way to use it. It's only in the last couple of months that we got some consensus recommendations for how to use it even in motility disorders. So it's a pretty new thing that's evolving.
And then we have this new diagnostic tool, this string test that we have
Mhm.
that's been approved. How can that play into it to maybe prevent patients with EoE from getting quite so many of these repeat biopsies as we try to figure out how to treat it?
Yeah, this is a really promising technique. And the issue is right now, EoE is so endoscopy heavy, right? We have to do endoscopy to diagnose it, which isn't going to change. But we have to do endoscopy now after every treatment change, or if you're doing diet elimination, after every food reintroduction. And it's obviously a huge burden, and it can be hard to get those procedures. Um, I think scheduled as well, right? For if you're managing someone primarily, especially on the allergy side. And so what the string test is it's a capsule that has a string in it that you swallow, and then you hold the string outside of the body and tape it to the cheek. And the string basically unfurls in the esophagus, and the capsule dissolves. Over an hour, the string will absorb inflammatory factors and other factors from the esophagus. and then the string is just removed. So it's a pretty simple test. It was developed about actually more than 10 years ago now, first as a 24-hour test, and then ultimately optimized as a 1 hour test. And it was developed in kids to start with as well to try to minimize endoscopies. And so ultimately now, when you take the string out, it gets sent to a lab and they measure major basic protein, one of the eosinophil granule proteins, and eotaxin 3, the main chemokine that brings eosinophils to the esophagus. And so, of course, we just had our discussion about eosinophils, but this is a pretty eosinophil level focused test. But it's got really good sensitivity and specificity, 85% plus of each, agreeing with endoscopic biopsies. And so I think the perfect place for this is longer term monitoring of patients to decrease the need for endoscopy. So, the kind of person who would be good for this is, you've got them diagnosed, you've got them in remission, and then, you want to minimize endoscopies. And so you could give them a string test in clinic, just takes an hour to check in how they're doing. And if it's negative, you're pretty comfortable that there's not inflammation coming back. Um, and then the other group I think it's really good in is the diet elimination, right? So if they have a response to diet elimination, what I might do in that group is you do the endoscopy that shows the elimination worked. Maybe you drop a string to make sure it correlates and is negative. And then you can just do the string after each food reintroduction. And you can probably do that rapidly, like every 2 to 3 weeks, rather than having to wait like 8 weeks for another scope and have the patient go through that whole process and expense. This is, of course, far less expensive. The group of patients who it's trickier to do in, of course, they have to be able to swallow a capsule. But those patients with like strictures who are needing a lot of dilation, those are people who I think, are better served with endoscopic monitoring because you're going to end up doing a therapeutic intervention. Patients who still have symptoms after you give them treatment, there it's not just a question of is whether there's inflammation or not, but is there a motility issue or an ongoing stricture? So those people probably stay in the endoscopy lab. But I think this is going to be very helpful for a large number of people.
And is it approved down to age 12? Because I imagine younger than that would be very difficult for them to swallow, hold it, for an hour.
Yeah, I think it may be younger than that. It may be 8. Yeah, when they tested, I'd have to double check that. But once you swallow it, the string comes over to the side of your mouth, and after a few minutes, it actually there's no the sensation kind of gets extinguished. And if you sip of water a couple of times, it's fine. And we're just starting to do this in the clinic. But what I've done is have people swallow it at the very beginning of the visit. And then I actually conduct my clinic visit for 20, 30 minutes and talk to people. They're totally distracted. And then they just have to wait another half hour for this to get removed. And so that's worked out well so far.
Can you drink while you have it in, or just when you're
Yeah,
initially putting it in?
you can have a few sips of water. Yeah.
Yeah. Oh, no. I think that'll be great for our patients just having to try to minimize some of these endoscopies that we're doing while we're trying to work out which foods to reintroduce.
Yeah.
And then speaking of treatment, so you had mentioned before that it used to be we would use PPIs as kind of a diagnostic tool, and now they're being used much more as part of this kind of larger treatment algorithm. And we have a number of different treatments that are all thought to be relatively equivalent in some ways. Um, how do you start talking with patients about what to do and the order in which to do it?
Yeah. For me, the biggest distinction is finding out if a patient wants to do medicine or diet. And a lot of times people come to me, they already sort of know the answer. But it's really, I think patients break down into ones who really want to avoid medicines. They want to know the underlying causes. They want to be able to, treat things naturally. You'll hear them say that sort of thing. And then, the other group who is like, they're like, I can't have beer and pizza. I'll just take a medicine, right? And, or so they're not interested, or their lifestyle is such that they can't really do diet. I think diet is a great treatment in the motivated person who understands the current process for that. And so for me, it ends up being about a third of my patients I would say might opt for diet, but it's really variable based on practice. There's some practices, particularly pediatrics, where nearly everything is diet, and there's other practices where nearly everything is medicine. And it also depends on sort of the comfort level of the doc, and also whether you have the infrastructure to support diet elimination.
think it also depends on the food, how the food elimination is going. I often have patients that are very willing to do, for example, dairy and wheat. And then when we start getting beyond that and they're traveling for work or it becomes much more tricky to do.
Yeah, and there's some good data now that's starting with dairy alone or dairy and wheat makes much more sense than doing the more traditional six food elimination with dairy, wheat, eggs, soy nuts, and seafood. And the Seeger group, which is a NIH funded multi-center consortium, did two trials. One was in adults of dairy elimination alone or a one food versus the six food, and then another one in kids, one food versus four food. And we all thought that, the more restrictive diets would be much more effective based on, the previous data, but it turned out it wasn't the case at all. And the response rates were about 40% across the board. And and obviously doing a one food diet's way easier, right? You don't really need a dietitian. You can explain to patients what to do. It's an imposition, but it's not, as life changing as doing those more restrictive ones. And so, I think it's a very nice way to start. And actually, our newest ACG guidelines recommend if you're going to do diet elimination to do an empiric elimination and start with a less restrictive diet, potentially based on those data.
Do you tend to start with a one food or a two food elimination and then keep adding, or how do you tend to do it?
Yeah, so if a patient wants to do diet, I tend to do a two food because again, like a 40% response rate is okay. It's not that great, and at least at our center, dairy and wheat are above and beyond the top two triggers. And it's not that onerous of a reintroduction process either. So depending on the patient, some people may just want to do dairy, but I tend to recommend a dairy and wheat elimination to start with. And then I would generally provide them resources, offer a dietitian visit, and then they treat them for about 8 weeks and then see about what their response is with an endoscopy. And if they don't respond, then I would get more restrictive. So I would go to a four food elimination. So dairy, wheat, egg, and soy, if they're really committed to doing it. And I think that's a point that a lot of people get confused about. Some people would say, oh, you didn't respond to dairy and wheat. You could add those back and instead eliminate egg and soy. But the problem there is if your triggers are dairy and egg, both of those are going to be flared up. And so you've got to always become more restrictive if you're doing this kind of process. Um, and of course, if they respond to the dairy and wheat, then I would add back a food, generally wheat, and do another scope. You could do a string test at this point now too. But if you add back wheat and they're still in remission, you're done because you know that dairy is the trigger. And so it's a pretty efficient way to do that.
And now, what about swallowed steroids? How do you talk patients through swallowed steroids, especially now that there is an FDA approved formulation
Yeah.
for EoE?
Yeah. So if they decide to go the medicine route, I will say that I usually will start a PPI first. Again, the response rates are about 40-ish%, and but it's just inexpensive and easy to get. And so it's not usually an issue to get the meds. And again, if respond, it can be a very good longer term treatment for them. The key thing about that, before I get to the steroids, is that you do have to tell patients that they're not getting this for GERD. And I explain to them that, hey, this is going to be a higher dose. This is going to be, so we like to use like twice the reflux dose. And it's going to be because PPIs treat EoE through a number of mechanisms that are not related to the reflux mechanism. And so once they understand that, even if they get it over the counter where the box says don't take this more than 2 weeks, then they understand what they're doing. So I'll usually start with that, but if they don't respond to it, then we'll go into the topical steroids. And these days, I do try to start with the budesonide oral suspension, which is Eohilia. This is the one that's FDA approved, and it's approved at a dose of 2 milligrams twice a day for 12 weeks, and it's approved in 11 and above right now. And this is much easier than going through the whole song and dance previously about mixing the budesonide into a slurry and how to make it, and then wondering what the patients are actually doing, or trying to have them do the fluticasone inhaler, and are they doing it correctly, and did they get the right dose, and do they get a spacer that they're using by accident from from the pharmacy, and all kinds of stuff like that. So I do try to use the budesonide oral suspension now. The tricky thing there is if they have a good response, it is only officially approved for 12 weeks, even though there are quite a lot of data, both for that med and for all the topical steroids that they work long term. So generally, I do try to make the request to the insurances to use it, and often I will try to lower the dose to 2 milligrams a day for more of the maintenance use. Um,
And this,
but I'll talk to the patients about the good safety profile, low systemic absorption, those sorts of things.
and this is really a long-term disease. And so, this idea that you can only treat for 12 weeks, what's beyond that?
Right. And so, there's some technicalities of why the med didn't get approved longer term, but there's now data up to 4 years from their initial study program showing efficacy and safety for that long. So I think we're on solid ground as providers recommending it. But I think it's an ongoing discussion about what the best treatment is for a patient at that time. Again, there's not that many long-term side effects that are coming out because of the low doses and low bio availability. But one thing is we often talk about treatments in EoE as an either or, and there may be times for people where a topical steroid is better, and then they want to go to diet later. So, for example, there I might see someone who's like 16 or 17 and about to go to college, and I know like diet is not going to be a good idea for them. So I might say, let's do a steroid for a couple of years. We'll come back and revisit, whether you want to do diet down the road. Um, and so, I have those kind of conversations with the patients too.
Yeah, no, absolutely. And then what about patients who want to do a diet, but maybe there's going to be times where they're traveling or they're going to be with, family and it's going to be very difficult to follow your diet? Do you combine the diet and steroids back and
I
forth?
I do, and I actually give people diet holidays. The data on long-term diets are that if you can stay on them, they're very effective. But about half of people, even when they've gone through the initial process and the reintroduction process, about half will still stop the diets long term. And so ways to make that better are that they can be off the diet for a little bit. If it's going to be a short period of time, this isn't, an anaphylactic allergy. So nothing, they may get symptoms, but it's not like they're going to cause terrible damage with being off the diet for 2 to 4 weeks. But I do have a number of people who, they'll go on topical steroids for a period of a few weeks or a few months around the holidays and then go back to the diet. If they go on vacation or travel, right, they'll go back onto a steroid. And that's another reason that I often start with PPIs. If they respond to PPIs and then do a diet later, they could easily go on a PPI for a month or two also. So I think switching that around and understanding, what the patient's preferences are helps for longer term therapy.
How long before the steroids start to be effective? Is it within a week? Is it pretty quick?
It's pretty quick. There was one study of a budesonide dissolvable tablet in Europe that showed biologic efficacy within 2 weeks. For most patients, though, I caution them that it may be 2 to 3 months before they really start seeing a symptom difference. And part of that is always with the context of do they have a stricture or not, right? So if they have a stricture and I dilate them, then their symptoms are gone or improved, and I can't really, follow them. But if they're just getting one of the medications, I also caution them that you may not feel better when we do your next endoscopy because there could still be a stricture there that needs to get dilated. And so I see people all the time who tell me, oh yeah, I took budesonide for a month, it didn't work, I didn't feel any better, I stopped it, so I need a different medicine now. And I actually have no idea if that medicine worked the way it should have with them just taking it for a short time and stopping it.
And then when do you start to move patients to biologics? And so we have one approved biologic, dupilumab. I'd also love to hear what's on the horizon, but when do you move to a biologic?
Yeah, so you are all far more familiar with dupilumab than I am, but I think at EoE and the most recent guidelines kind of echo this. That in general, it's going to be a step up med, and that's primarily because of the systemic nature, the injection, and the cost. So, and quite honestly, the insurances are being gatekeepers. It's interesting for dupilumab, the approved indication is just EoE. There's no moderate to severe like there is for eczema or asthma. So it could theoretically, by the label, be used in anybody, but most insurances are gatekeeping it to treatment failures or people who are intolerant to medicine. So I generally have people both fail PPI and steroids or have side effects or intolerant to those before I go to Dupy. And in fact, here in North Carolina, I actually can't get it approved unless I have documentation of failure to each of those medicine classes beforehand. I don't think that's the case everywhere. And talking to colleagues, say in Massachusetts, it seems like it's easier to get it approved up there. Um, but that's the general. Now, there are times where it can be used earlier, and the main time is if someone has another atopic condition that might merit GP use as well, right? So if someone's got pretty prominent eczema and asthma, or one of those, or nasal polyposis, and that would be a time to consider it because you might be able to spare someone 4 different steroids, right? Um, and so I think that's a really nice use early. But I will caution, all the trials that we have so far and all the data are in PPI non-responders, and most of the patients are in steroid responders. So we have very, very few data, if any, on like a newly diagnosed EoE patient. I think a lot of people are talking about, okay, well, if someone's really severe when they come in, shouldn't you just start it? And I think it's an interesting question, but from a guideline standpoint, there's no evidence for that.
And then what other biologics do you see on the horizon, or other treatments do you see becoming kind of used for EoE?
Yeah, there's a few on the horizon. There was an anti-IL-13 called cendakimab that just completed phase 3 trials, and the trial was positive. But for business reasons, the company that was making this isn't pursuing it for approval right now. But I mention it because it was an effective medicine, and so that may be coming back at some point. Right now, there's tezepelumab, which is approved for asthma, and that's in a phase 3 trial for EoE that's finishing up. And so that'll be the next one that we'll get some data on. Not much clinical experience with it at all for EoE, but certainly as a med that blocks TSLP, it's a very attractive treatment target for EoE being at the very top of the inflammatory cascade, even before the T cells. There's a very interesting med in phase 2 trials right now called barzolvolimab, which is a KIT inhibitor, and it's an antibody that depletes mast cells. So what's interesting is we did the experiment depleting eosinophils, and now we're going to have the same experiment on mast cells, and we'll see what happens, or whether someone needs both of those medicines to deplete eosinophils and mast cells. But that's a pretty interesting mechanism as well. So those are and then there's another anti-TSLP under study as well, called solritatug. And so those are the biologics that are being looked at right now.
Do you think we're going to start phenotyping our EoE the way that we do in so many different diseases these days? Because it seems like, maybe you're someone who is more, mast cell mediated, or perhaps this is acid responsive, or perhaps I think that it looks like we're going to start having that kind of distinction.
I think so, and I think that's been the hope of a lot of people. There's a pretty interesting paper also from the Seeger group that did cytokine profiling in esophageal biopsies, and there are exactly people who are really high in TSLP, but maybe not as high in IL-5, and others that are high in IL-13 but not in TSLP. And so I think there are going to be these kind of phenotypes, and hopefully that will help us direct things as we get more biologics um, out and for patients. Um, and most of the studies are collecting samples for that kind of biomarker analysis, which is it'll be pretty interesting to see how that stuff turns out.
Now, EoE being the most common of the eosinophilic GI diseases, but certainly there's eosinophilic colitis, eosinophilic gastritis. We don't really have any treatments for those at this point. How are they different, and how are we going to target them, do you think?
So yeah, it's pretty interesting. These are at least 1 to 2 factors more rare than EoE. And so we're talking, EoE is now about 1 in 700. These are probably still 5 to 10 per 100,000. So pretty uncommon, but also probably underdiagnosed and not appreciated. Eosinophilic gastritis and enteritis, there's pretty strong data that these are probably T2 driven diseases as well. And just recently, a study was published where elemental formula was given to patients with those conditions, and they all got better, 100% of them. So pretty strong evidence it's food driven there. And that's the same kind of evidence back in the 90s that we had for EoE to show that it was food driven. Um, Eosinophilic colitis is the rarest of them, and it does not have the same T2 signature. And so that's really unclear if it's T1 and to what extent it might overlap with, inflammatory bowel disease, which can be eosinophil predominant. So it's a little bit different. In terms of treatment, there hasn't been anything really tested for eosinophilic colitis. For all of them, steroids are sort of the mainstay right now, whether you're using systemic steroids or whether you're trying to adapt like an enteral release budesonide to target different parts of the GI tract. But there's pretty interesting emerging data. So actually, I was just at DDW, which is our main GI meeting of the year, and there were two trials presented out on eosinophilic gastritis. One was the cendakimab anti-IL-13 medicine I mentioned. That was done in Japan, actually, where eosinophilic gastritis is actually more common probably than EoE right now. And that was effective for eosinophilic gastritis. And then here, the Seeger group reported out the DEGAS study, which was dupilumab for eosinophilic gastritis. And that also met the primary endpoint. We saw good histologic improvement, good endoscopic improvement, good genetic improvement as well. The study wasn't powered for symptoms, but there was a numeric improvement in the symptoms. So I think very promising for those conditions. So I think there'll be more coming out relatively soon on those.
Well, this was fantastic. Thank you so much for taking the time with us today. Do you have any take-home points you want to make sure that people leave with?
I think there's a few. I think, from the allergy standpoint, I think you all are seeing a high risk population. And I know there's a lot on your plates during the visits, but having, thinking about asking about some GI symptoms and maybe even the adaptive behaviors may lead to people getting picked up earlier and diagnosed earlier, maybe before they progress to when I have to see them as in the food impaction kind of setting, going back to my fellowship. But I think there's a chance you could pick those up, finding out if other people in the family have EoE or or trouble swallowing, those kind of symptoms. So I think that's one thing. The other is really the new guidelines suggest that when we think about treatment, in addition to that big distinction between medical and diet therapy, there's really a consideration of thinking about your anti-inflammatory therapies in parallel with what's going on with fibrostenosis. And really keeping a thought that if people are continuing to have trouble swallowing, most likely there's going to be a stricture there. And for me, anybody who has a food impaction has a stricture until proven otherwise. And so it is an important part of the condition to think about. And then, yeah, I think for me, it's been, the collaboration between GI and allergy has been, wonderful. I've learned a tremendous amount, but, I refer many patients, to allergy. The paradigm is changing, right? We're not doing, you're not doing the IgE mediated food testing to direct the diets anymore. But I think, the expertise and the knowledge about managing other atopic conditions, your knowledge of the biologics already that we're just starting to learn of in GI for these conditions, is just so important. So I really value that collaboration in clinical care and in research.
Well, thank you so much.
Yeah, thank you so much for having me. This is great.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any question pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology's Terms of Use Agreement, which you can find at their website. Please visit quadia.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to rate and subscribe through wherever you download your podcast. Thank you again for listening.